Hello, this is part 2 of the chapter on circulation. We're picking up here with arterioles. These are the vessels that are largely responsible for managing the resistance. They're small in diameter. They have a thick wall relative to how big the lumen is, meaning they have a lot of muscle. The vascular smooth muscle cells. This is the stuff that is going to respond to local factors and to our nervous system stimulation, as well as some other mediators. And so we can have a quick response, a quick change in blood pressure. If I didn't mention it before, this part 2 is going to be largely about managing blood pressure. So it helps to maintain arterial blood pressure, flowing against gravity, that is trying to keep blood going up to the brain. Determinants of blood pressure. This is the only equation of all the equations in this textbook, not in this textbook, in this chapter. This is the only one I'm going to put up here because it's pretty straightforward and you already know it. The mean arterial pressure, MAP, equals the cardiac output, that is the pump, and the total peripheral resistance. In other words, how much are the tubes squeezing? So those two factors, the pumps and the tubes, are largely responsible for the mean arterial pressure, determined by what the pumps and the tubes do. Next chapter is all about the pump. So we'll leave that for then. Peripheral resistance, we said it's this vascular smooth muscle contraction and dilation. So the tubes have to integrate a lot of different signals. There's going to be stuff happening locally. There's going to be signals coming from the nervous system. There's going to be other signals from hormones, the signals like angiotensin. There's also some vasopressin going to be playing a role. And so the blood vessels integrate all that information and come up with some like compromise amount of contraction. We've mentioned arterial compliance. That helps. So when the blood vessels can expand, when the heart contracts and the blood vessels expand, the arteries can expand, that is going to keep the systolic pressure from going too high. But as we lose that compliance, as we lose the stretching and then the recoil, we get a bigger and bigger and bigger difference between systolic and diastolic numbers. Summary, just a visual of the mean arterial pressure being a product of the cardiac output, what the pump is doing, along with the total peripheral pressure, what is happening in the tubes. Pressure drops along the circulatory path. In other words, in the very large vessels, aorta and other large arteries, that's where we're going to have the highest pressures and where we're going to see the pulsatile nature of the pressure. It goes up, it comes down, it goes up, it comes down. It doesn't go down to zero, but it does come down. And the reason we're seeing this is because the heart contracts and then it relaxes and then it contracts and so on. And that pulsatile nature that diminishes as we go into the smaller and smaller and smaller vessels until we finally lose that altogether by the time we're in the capillaries and the veins. Consequence of increased arteriolar resistance. I like this analogy. This is from our textbook. So if the beginning of the hose is coming out of the heart and the aorta, and then we get further along, we're going in the arteries, and then we've got the capillaries here. When the arterioles contract, what happens is they increases the pressure back here in the larger arteries, but it decreases the pressure in the capillary. So we actually get less stuff coming out into the tissues. So arteriolar constriction increases blood pressure, but reduces pressure in the capillaries. I'm going to mention this now. We're going to talk about different medications that are used to manage blood pressures, but one kind of calcium channel blocker, we actually see this side effect that the patients actually end up getting edematous as a result of a release of this pressure. So the certain kinds of calcium channel blockers cause a release in the arteriolar pressure. That's going to lower the pressure in the larger arteries. But look, you're getting more squirting out by the capillaries. You're actually going to get more edema out in the tissues. And I just wanted to point out that, some of these side effects just seem counterintuitive, but this is the explanation for that one. Okay, short and long-term blood pressure regulation. A little bit busy. This is our author's attempt to simplify things, and I'm going to just break it down for you. We're talking about the tubes, the pump, and the liquid in the tubes. So the tubes in the pump over here, short term, quick response. We have this baroreceptor reflex that we're going to talk a little bit about. So very quickly we detect what the blood pressure is by receptors that are in the aorta and the carotids, and that information gets fed, integrated, and then there's some motor output to the blood vessels and to the heart, so cardiac output. And so we're going to get a quick change in the blood pressure. And then there's also longer term changes that we do by managing the volume of the liquid in the tubes. That's going to involve, if you need more liquid in, you can do a couple of things. You increase thirst, makes the person want to drink more water. And we can make the kidneys hold on to some more of that water. But these changes in the liquid volume, that's going to take a little bit longer than clearly the muscular changes that we can have change like that with the nervous system. So these longer term adjustments, the renin, angiotensin, aldosterone system, and vasopressin. So this, I'm just mentioning it in passing, but at the end of this part 2, I'm going to go over renin, angiotensin, aldosterone system. If you know it backwards and forwards, you can skip that part. But if you need a little refresher, I'll go over it. All right, so here are all the different things, the different factors that can affect our blood pressure. So things that are going to affect the pump, the heart. The heart itself can produce the cardiac natriuretic peptides, ANP and BNP. So that's going to have an impact on the liquid in the tubes. These things are going to cause a change in fluid volume. They have an impact on the kidneys and an impact on what the blood vessels are doing. Then remember, endothelial mediators inside the endothelial cells inside the blood vessels can produce nitric oxide and prostacyclin. Both of those can cause dilation, relaxation, and they also inhibit clotting. Immune system, what? Yeah, remember we talked about histamines and prostaglandins. These are things that are released by the mast cells. Remember the 3 things that cause a vasodilation, they cause bronchoconstriction, but they also cause leaky capillaries. So that's going to affect the tubes. It's going to cause relaxation of the tubes, and it's going to cause leakiness in those capillaries. So less liquid in the tubes. And then parasympathetic nervous system. These are things that are lowering the blood pressure. So stimulation from the vagus nerve affecting the heart, that's going to tell the heart to slow down. Vagus nerve, parasympathetic, heart, slow down. Time permitting, I'll tell you a story about that. So lower blood pressure. On the next slide, let's see things that raise blood pressure. Sympathetic nervous system stimulation. We've got norepinephrine that can come from the neurons, the sympathetic neurons, going to the heart and to the blood vessels. Those are going to say to the heart, contract harder and faster. To the blood vessels, tell the smooth muscle of the blood vessels to contract down. It's going to raise blood pressure. Also coming from the adrenal glands, we've got epinephrine and some norepinephrine, the adrenaline rush, make the heart beat faster and the tubes squeeze harder. Then the renin, angiotensin, aldosterone system, these each in a variety of ways will cause the blood pressure to come up. As I said, I'll go over this in a little bit more detail on another slide. And the endocrine system. There's a hormone known as vasopressin, sometimes called arginine vasopressin, also known as antidiuretic hormone. So the name vasopressin tells you the vessels are going to they're going to squeeze. The antidiuretic hormone also tells you, it's going to tell the kidneys, don't pee so much, hold on to some of that water. So it has an impact on the blood vessels themselves, and it has an impact on the liquid, on the blood volume. All right, so this is the reflex, compensate for short-term blood pressure change. Let's say we're going from a lying down position to a standing up position. We need quick, we don't have time to be like changing the blood volume then. So whenever you have a reflex, you have to have sensory input, and then you have motor output. So sensory input, we've got the stretch detectors in the carotids and in the aorta. That's going to be relaying information to the brain. The motor output, if the blood pressure is too low, like we just saw in the previous slides, the sympathetic nerves to the heart will tell the pump faster, harder. Sympathetic nerves to the blood vessels they increase firing. I'll get back to that in a second, making the tubes constrict. So that's going to happen quickly. This one's going to be a little bit slower. The message goes fast. The sympathetic nerves to the kidney is going to kind of initiate this renin, angiotensin, aldosterone system, but the response is a little bit slower. So we need the release of the renin. This is sometimes pronounced renin. They're both correct. And that's going to impact the tubes themselves as well as the liquid in the tubes. Now, if the opposite situation is the case, the sensory input is saying the blood pressure is too high, then what do? Well, parasympathetic neurons in the vagus nerve, they tell the heart to slow down, chill a little bit, pump slower, not so hard. This is the thing that's a little bit confusing to people. We don't have parasympathetic neurons going to the blood vessels. We only have sympathetic neurons going to the blood vessels. And so to get the blood vessels to squeeze harder, we increase firing from these neurons, and the tubes respond by constricting. To get things to relax, we don't have a parasympathetic, comparable parasympathetic stimulation. We still just use the sympathetic nervous system. And what happens is we slow down sending the signal that says contract, contract. And so we have decreased firing from those neurons. Same result, the tubes dilate. The smooth muscle relaxes a little bit, which will help bring the blood pressure down. Just a flow chart saying if we have the blood pressure's too low, send that signal into the brain, and then the output is increase sympathetic nervous system stimulation. That's going to bring up the pump, it's going to pump harder and faster. So faster and harder. That's going to increase cardiac output and cause the blood vessels to constrict more, which is also going to bring up the total peripheral resistance, which brings blood pressure back up. All right, so as you know, the system is not perfect. Sometimes it gets out of whack, and a big problem that we have to deal with our patients is hypertension. It has been redefined. We now call hypertension anything over 130 over 80. That is by the American Heart Association. We actually don't know what the cause is of hypertension in 90% of the patients or more. We don't know. So it's referred to as primary or essential hypertension. So we have to, put an ICD-10 code down, but we still don't know what's causing it. our textbook describes two major hypotheses about this. I've grayed out one of them because it's kind of dated information. So we do think that there's chronic sympathetic hyperactivity causes chronic vasoconstriction. This is one of the reasons that one of the lifestyle adjustments that's recommended is reduce stress in the life to try to help bring down that, sympathetic nervous system's chronic stimulation of blood pressure. This next one, this abnormal renal sodium and water retention, expanding circulating volume. It is true that we see that there's some sodium abnormalities and too much water is being retained. However, it's turning out that for most of our patients, that adjustment in sodium, dietary sodium intake, isn't having the huge impact that we thought it would have on blood pressure, which is why I have grayed this out. It's not that we don't talk about it anymore, but we're starting to realize some other factors may be more important. So risk factors, we've already mentioned, non-modifiable things like family history, race, ethnicity. The modifiable ones, look, it's some of the same stuff that we associated with endothelial damage: smoking, obesity, diabetes, hyperlipidemia, in other words, metabolic syndrome. Why we think that this is mostly related to this chronic overstimulation of the blood vessels is when we look at the patient's cardiac output, that part of the equation is normal, which suggests that we have a chronic increase in total peripheral resistance. The tubes, in other words, are contracting too much. Okay, in a small minority of our patients, 10% or less, that have hypertension, there is some other identifiable problem that's leading to the hypertension. We call that secondary hypertension. The most common problems, of course, would be kidney failure. So the patient is unable to excrete adequate amounts of water or some electrolytes. That's going to result in increased blood volume. So too much fluid for the space in those tubes, that's going to jack up the pressure. And so the way to manage this most effectively is by treating the kidney problem, the underlying kidney problem. And then there are some identified endocrine disorders, a variety of different kinds that lead to increased cardiac output or peripheral resistance, or both things, like hyperaldosteronism, hyperthyroidism, pheochromocytoma. These are tumors that are making epinephrine and norepinephrine. Hypercholesterolism. There's a typo. But the addressing the underlying cause can help fix the hypertension. But that, like I said, is in a minority of our hypertensive patients. Most of them, we say they have primary or essential hypertension. All right, now what's the effect? Like, why do you even have to bother treating hypertension? Well, there are some consequences. One is that the situation just gets worse, because when the patient is experiencing this extended period of hypertension, the baroreceptor, that reflex that's supposed to bring the blood pressure down, the receptors reset and they stop firing, saying, hey, we got to bring that blood pressure down. It's like oh, this is the new normal, so we're not going to overreact to this. This is just what we maintain now. The vascular smooth muscle cells, we've talked about this. When you have a lot of exercise, you grow. So we have hyperplasia, more cells growing, and hypertrophy of those cells, so they get bigger. That thickens the walls, stiffens the walls. This is a particular problem with the kidneys and a predisposing factor for kidney disease. We see with the hypertension, we see an increase in atherosclerosis. in the formation of aneurysms. Remember, behind the atherosclerotic plaque, you've got that turbulent flow, and that can cause distension of the blood vessel wall and possible rupture of the wall. In the coronary arteries, we see increased atherosclerosis. We have, all right, so the heart has to work against all this high pressure. So we see ventricular hypertrophy. That is, the cardiac muscle cells themselves are getting bigger. That means they need more oxygen, but we have limited blood supply to the heart because of the restriction on the coronary arteries. So this just gets worse and worse and worse. This leads to heart failure in slow motion. And then if there's a thrombus or a plaque that ruptures, can lead to myocardial infarction. The early stages, why this is a really big problem, is the early stages of hypertension are asymptomatic. There is no pain. It does not hurt. And so the silent, it is silent. The damage starts to accumulate without anybody being the wiser. All right, so what's the recommendation for managing hypertension? Lifestyle, dietary approaches to stop hypertension, there's weight loss, exercise, smoking cessation, reducing stress, reducing sodium, which we said in some patients is effective and in other patients it's not, reducing alcohol intake. Now, the pharmacological interventions, these will not fix the underlying problem. What they do is treat the symptoms. It does not cure the problem. So to address how tightly the tubes are squeezing, we have ACE inhibitors and angiotensin receptor blockers. Again, I'm going to talk about that on the next slide. How much liquid is in the tubes? The patients may be prescribed diuretics to try to get rid of some of the extra fluid that's in the tubes. And again, going back to the ACE inhibitors and the ARBs, this is going to lead to less aldosterone, which the aldosterone would be causing the body to hold on to the sodium and the extra water. And finally, that third factor, the pump. We want it to slow down and not pump so hard. We've got beta blockers, we've got calcium channel blockers. And these can also affect how hard the tubes are contracting. Generally, patients are prescribed one medication to start. They may be given a second medication, but when multiple medications are being prescribed, it's a combination of things. Like the patient wouldn't initially be given both an ACE inhibitor and an ARB. Like those would both act on the tubes. Like, why don't you, like, if you're going to have side effects, why don't you like spread it out a little bit? Have an ACE inhibitor and maybe a diuretic, balance things out. So you're acting on two fronts instead of just one. And finally, this is that diagram to review renin, angiotensin, aldosterone system. If you know this cold, you can go ahead and end the part 2 here. If not, go ahead and listen in on the review. This part of the diagram is in the kidney. The kidney is stimulated to release renin. A number of different things can cause that to happen. A decrease in the mean arterial pressure, an increase in norepinephrine. The nervous system can stimulate this to happen, and having low sodium can stimulate this to happen. Any of these triggers the release of renin. Renin by itself, not doing a lot. However, it activates a protein called angiotensin 1. Angiotensin 1, back up. There's an inactivated form of angiotensin 1. It's called angiotensinogen, so angiotensin generator. It gets stimulated, it gets activated by the renin, becoming angiotensin 1. Again, still not ready for action. Angiotensin 1 has to be activated to become angiotensin 2. What does that is in the lungs. There is an enzyme known as angiotensin converting enzyme, or ACE. The ACE activates I'm going to say it one more time, angiotensin 1 into angiotensin 2. This is one of the places where our medications act, the ACE inhibitors. They interfere with this conversion. And so although renin is being released, we're not getting to the active signal over here. And so that's how we interfere with the system. The other place that can be interfered with is on the reception of the angiotensin 2 signal. And that's where the ARBs come in, the angiotensin receptor blockers, ARB. What did I want to tell you about that? Oh, I know. So the ACE inhibitors, the prils, lisinopril, for example, some patients can't tolerate them. They have this side effect. Some people get this dry cough. It's just annoying. This is a way of remembering that side effect, or vice versa. If you know the side effect really well, this is remembering that angiotensin converting enzyme, that activity that's here in the lungs. So that side effect, the coughing, is here in the lungs. So some patients cannot take the ACE inhibitors, in which case they would be prescribed an ARB, an angiotensin 2 receptor blocker. All right, so what is going to respond to angiotensin 2? I'm so glad you asked. We have vascular smooth muscle. So that's going to, and actually the name tells you, angio, the blood vessel, tension. It's going to cause the blood vessels to constrict. It also increases the strength of contraction and the frequency, the rate of the heart, and going to increase blood pressure by increasing cardiac output. But wait, there's more. There's also receptors in the adrenal cortex. That's going to lead to the secretion of a hormone called aldosterone. That's the third player here, the renin angiotensin aldosterone system. Aldosterone, how are we going to remember what aldosterone does? Well, if you learned hormones the way I learned hormones, you may have learned aldosterone at the same time that you heard about aldosterone and antidiuretic hormone. They both start with A. They both cause the body to hold on to more fluid. I mean, how to remember which one's which. And the way I came up with for myself to remember this is aldosterone. So that sounds like an Italian guy, aldosterone. And this Italian guy, I picture him as this really nice guy making this really nice Italian sauce. And if you're going to make a really good Italian sauce, you need some salt. And salt, Aldo is the one who's going to hold on to the salt. And so aldosterone causes the kidney to retain sodium. And wherever the sodium goes, that's where the water is going to go. And so aldosterone causes an increase in blood volume by retaining the sodium and having the water stay with the sodium. And that is my renin angiotensin aldosterone story for you. So all these different players, they have different roles to play, but in the end, all of them act to bring blood pressure. And that is the end of part 2.